I'm going to start my head-to-toe assessment of my patient with the pre-procedural steps. Then I will move on to checking my patient's vital signs, their temperature, blood pressure, respiratory rate, heart rate, and their blood oxygen levels, and also assessing them for any pain they may have. Next, I'll move on to assessing my patient's appearance and behavior, noting that the patient is appropriately dressed and appears well groomed. And then for behavior, that the patient appears to be alert and oriented to their surroundings and appears to be behaving appropriately for the situation. So I'll move on to my JOMAX assessment. For their judgment, I'll ask my patient what they would do in the case of a fire. For orientation, I would make sure my patient is oriented to person, place, time, and situation. For person, I would ask them who's the president. For place, I would ask them where they're at. For time, I would ask them about what time of day is it. And for situation, I would ask why are they here. After I've done orientation, I can move on to testing my patient's memory. So for this, for immediate recall, I would instruct my patient to please repeat after me. All dogs go to heaven.
All dogs go to heaven.
Okay, and then I would test their intermediate recall by asking them, what did you have for breakfast yesterday?
Oatmeal.
Okay, and then for long-term memory recall, I would ask them, when is your birthday?
March 19th.
Okay, so I note that my patient's memory is intact, so I can move on to the patient's attention. So I note that the patient is properly attentive and is able to maintain their attention. They're not easily distracted and they respond to my commands properly. So, and for cognitive, I would be assessing my patient's cognitive state throughout the beginning of this assessment, noting that they appear to be, their thought process appears logical and intact, and they are appropriately responding to me and my commands. And for speech, I will be assessing the patient's speech, noting that it is clear, fluent, and is the appropriate rate. And that will complete my JOMAX assessment. So now I can move on to assessing my patient's skin. So the first thing I'll do is to inspect the skin and note that it is appropriate color for the person's race and ethnicity. I will then move on. There are no apparent lesions, scars, edema, marks, anything of concern. So I'll move on to palpating, noting that the temperature is warm, the texture is smooth, it is appropriately moisturized, not too dry, not too moist. And then I will also check the skin turgor and note that it returns to baseline within 3 seconds, or within 2 seconds. So that would complete my assessment of the skin. I can move on to the fingernails. So for the fingernails, I'll inspect and note that the fingernails are the appropriate color. The nails themselves are clear with pink fingernail beds. They are appropriately thick. They're concave in shape, and they're not cracking or do not appear brittle. I will check the capillary refill and note that the patient's refill is under 3 seconds. And then I will also have my patient place their fingers together, push your fingers together like this, and note that there is a diamond shape to indicate that there is no clubbing. So that will complete my assessment of the nails, and I can move on to the assessment of the head and hair. So the first thing I'll do is inspect my patient's head and hair and note that the head is normal cephalic in size and circular in shape, and the hair appears evenly distributed and appropriately thick. And I can move on to palpation. I'll palpate the head to make sure there's no masses, lesions, nodules, or protrusions, and that the hair is, again, evenly distributed. It is appropriately moisturized, is not too dry or too oily, and it is not shedding or brittle. I will then inspect the scalp to make sure it is intact and free of lesions, vermins, ulcers, scabs, anything like that, and it is. So that completes my assessment of the head and the hair. So I'll move on to the face. The first thing I'm going to do is to to inspect the face and make sure the facial features are symmetric and appropriately aligned on the face. I will then move on to palpating the frontal and maxillary sinuses to make sure there's no tenderness or drainage. And then I will also go ahead and palpate the lacrimal apparatus, again noting there's no edema or tenderness in those areas. And then I will also at this time go ahead and check cranial nerve number 7, the facial cranial nerve, by instructing my patient to smile, frown, raise and lower your eyebrows, and show me your teeth. So I note that my patient's cranial nerve number 7 is intact and functioning properly. So I'll move on to my assessment of the patient's eyes. First thing I'll do is inspect to make sure that the eyebrows, eyelids are symmetrical and aligned on the patient's face. I will then move on to checking the pupils for perla, and this is also where I'm checking cranial nerve number 2. I want them to be equal in size, round, and reactive to light, and to accommodate appropriately. So I'll place one hand in the middle of the patient's face, bring my light from the side, watching the left eye the first time and the right eye the second, noting that they are reacting to light and accommodating appropriately, and I would do this bilaterally. So I note that cranial nerve number 2 is intact. Then I'll move on to testing the visual acuity and with the 6 cardinal gazes, and this is checking cranial nerves number 4, or 3, 4, and 6, oculomotor, trochlear, and abducens. I'll instruct my patient, keep your head still and just follow my pen with your eyes. 1, 2, 3, 4, 5, 6. So I note that the patient's cranial nerve number 3, 4, and 6 are intact, and so is their visual acuity. And additionally, earlier when I was checking their pupils, I would also be checking for a red reflex and noting that it is intact. And I will also have inspected the eyes to make sure their sclera is white, and I would have my patient please pull down your eye and note that the conjunctiva is pink. So that completes my assessment of the eyes, and now I'll move on to the ears. So for the ears, I will just inspect first and note that there is no erythema or edema. I will then palpate the auricles to make sure there's no tenderness. And then I would insert my otoscope, inspect the tympanic membrane to make sure that it is a pearly white or gray color and shiny. And there should be a cone of light at 7 on the left ear and a cone of light of 5 on the right ear. And I'm also noting to make sure that their ear canal is free of debris and obstruction. And also I'll go ahead and check cranial nerve number 8, the acoustic cranial nerve, by doing the whisper test. So I'll whisper a phrase out of sight of my patient's eyes and have them repeat it to me. 1, 2, 3. ABC. So now I can note that my patient's cranial nerve number 8 is intact and functioning properly. So that can complete my assessment of the ears, and I can move on to the assessment of the nose. The first thing I'll do is inspect to make sure that it's symmetrical and appropriately proportionate to the face. I will then have my patient tilt their head back, inspect the nares individually to note that they are symmetrical and round, and that the mucous membrane is appropriately moist and pink, and there's no excess drainage. I will then test cranial nerve number 1, the olfactory nerve, with a patency test. I would have a cotton ball with a familiar smell such as alcohol. I would instruct my patient to plug one nostril, raise the cotton ball to the other nostril, have them inhale, and then tell me what they smell to check their ability to smell and patency. And this will confirm that their cranial nerve number 1 is intact and functioning properly. And so now I can move on to my assessment of the patient's mouth. I'll instruct the patient to open their mouth and say ah. And I'm inspecting to make sure that the lips, gingiva, mucosa, tongue, and the pharynx are all pink and moist. And then I'm also inspecting the dentation to make sure there are no missing or broken teeth or no caries, no dental caries. And I'm also checking cranial nerve number 9 and 10, the glossopharyngeal and the vagus cranial nerves. And to do this, I'm making sure that when the patient says ah, that their palate is rising midline and that their uvula is also midline and rising. And so this confirms that those cranial nerves are intact as well. And that will complete my assessment of the patient's mouth, so I can move on to the throat. So the first thing I'll do is inspect and make sure there are no visible masses, and then I will palpate to make sure the thyroid is not palpable and the neck should be supple. And then I palpate the trachea and make sure that it is easily displaced, and it is. And then this is also the time when I would go ahead and palpate for their lymph nodes, starting with the preauricular, postauricular, occipital, submental, submandibular, jugular-digastric, superficial cervical, deep cervical chain, posterior cervical, and supraclavicular. And I want to note that none of these lymph nodes were palpable, and there's no lymphadenopathy. I will also go ahead and check that patient for TMJ and cranial nerve number 5. the trigeminal nerve by asking them to open and close their mouth and clench your jaw. Noting there's no crepitus in TMJ, and so that will also confirm that cranial nerve number 5 is intact and functioning. And so that will complete my assessment of the patient's neck, and I can now move on to assessing my patient's cardiovascular system. So to do this, the first thing I'm going to do is to note the location of the heart. The base of the heart should be at the left sternal border, and the apex of the heart should be at the left fifth intercostal space at the midclavicular line. I'll be palpating for 5 different heart locations: aortic, pulmonic, Erb's point, tricuspid, and mitral. For the aortic and pulmonic, I'm listening for S1 sounds, and at the Erb's point, I'm listening for S1 and S2, and at the tricuspid and mitral points, I'm listening for S1. So I will go ahead and palpate now, or auscultate, sorry, now. Okay, so I note that all the heart sounds are present and appropriately sounding. So that will complete my assessment of cardiovascular. So I'll move on to peripheral vascular, checking the pulses. So I'll check the carotid pulse first, noting that it is present and +2. Do this bilaterally. Then I'll move on to the brachial pulse, the radial pulse, the popliteal pulse, the PT pulse, and then the top of the foot, the dorsalis pulse, noting that they are all present and +2. So then I'll move on to neurovascular assessment. And for the neurovascular assessment, I will, this is the 5 Ps. So my patient is not in pain. I'll ask them if they're in pain. They're not presenting with pallor. Their pulses, I just checked. They're all present and +2. I will ask my patient if they're having any numbness or tingling. So there's no paresthesis. And I know the patient has no paralysis, because that would have been apparent earlier on in my assessment of the patient. So that will complete my neurovascular assessment, and now I can move on to the respiratory assessment. So for the respiratory assessment, I'm going to be auscultating for 5 spots, 5 different locations in the front of the patient and 9 on the back of the patient, trying to stay in the center of the chest to avoid breast tissue. I'm listening for, I want to hear resonant lung sounds. I do not want to hear any adventitious lung sounds such as rhonchi, or wheezes. And so for this, I will go ahead and first I'll inspect the chest like I did with the cardiovascular, make sure it's symmetrical. There's no lumps or lesions. I can palpate to make sure there's no tenderness in the patient's chest, and then move on to auscultation. So, and for each one of these locations, I would wait for an entire inspiration and expiration before moving to the next. So I note that all the lung sounds are appropriate. There's no adventitious sounds, no rhonchi, rales, or wheezing. So I can move on to the posterior assessment. I would also check the AP diameter to make sure that the patient's anterior and posterior chest are at least 2 times as long as the depth of their chest. And so I confirm that that is the case. So now I can move on to the patient's back. If you please turn to the side for me right here. Again, I'm going to be auscultating at 9 different locations on the patient's back for an entire inspiration and expiration. Again, I note that there are no adventitious lung sounds. And now I'll move on to percussion. Percussion of the of the respiratory system, the posterior respiratory system. So I'm going to percuss again at the same 9 spaces that I just auscultated. And I want to note for, again, resonant sounds. I note that the sounds are appropriate. Over the lung tissue, they did produce resonant sounds, and there were no dull sounds that were produced. And so now I'll move on to checking for tactile fremitus. To do this, I will use the sides of my hand and place them on the patient's scapula and place it on the patient's posterior side and move around the scapula and have them say 99 each time I move my hands to check and make sure there's no fluid in the lungs. So each time I move my hands, say 99 for me.
99, 99, 99, 99, 99.
Okay? So I note that my patient is presenting with no tactile fremitus, which indicates there's no fluid in the lungs. And so, again, at this point, I would have also, when I was doing my inspection of the patient, I would have been looking for any type of labored breathing. My patient is not presenting with any, but I would be looking for things such as nasal flaring, use of accessory muscles, tripoding, things such as this. And I do not note any of these on my patient. So that will complete the respiratory assessment for the patient. And so now I can move on to the assessment of the abdomen. So now I'd instruct my patient to lie down and bring their knees up. During this part of the assessment, I'll make sure to only expose the part of the patient that is necessary. For this assessment, I will start with inspection, noting that the abdomen is flat and it appears symmetrical. And then I will also I will start with auscultation because I do not want to palpate or percuss and create any kind of false bowel sounds. So what I'm doing is listening for normal active bowel sounds, anywhere from 10 to 30 a minute, and I'm going to auscultate in all 4 quadrants, starting in the right lower quadrant, because this is where the opening and closing of the ileocecal valve is. And so here I go. I'll go ahead and auscultate. So I note that my patient is producing normal active bowel sounds that are low pitched. So this is appropriate. So now I'll move on to percussing the patient's abdomen. Again, I'll start in the right lower quadrant, go to the right upper quadrant, and around in a horseshoe shape. And so here I am percussing for tympany, high pitched sounds. This indicates that there are no fluid-filled organs that are being percussed, or nothing is inflamed. And I note that tympany was produced upon percussion, so this is appropriate for my patient. Then I can move on to palpating. For the palpation, I will start with shallow palpations and then go deeper, and I should not be able to, no organ should be protruding out from my patient. So I note that the patient's abdomen is soft and there's no inflamed organs that can be palpated. And so this is appropriate for my patient. So now I will ask my patient to sit up, and I will go ahead and check their kidneys, make sure they're having no pain. Here, just sit. You can sit right there. So I'm going to place my hand over their kidney and hit it with my fist. Any tenderness? No. Okay, then I'll move to the other side. Do the same thing. Any tenderness? No. Okay, so I note that my patient has no tenderness in their kidneys. So now I will move on to the musculoskeletal assessment. So I have my patient stand up. First thing I'm going to do is inspect the patient to make sure that their posture is erect, that the shoulders, scapula, and their lower back are all aligned and symmetrical. The first thing I'm going to do is to check for a scoliosis. So I'll start my hand at the bottom of my patient's back, have them bend over and raise my hand up as they do, and then have them lean back up and pull my hand back down, making sure there's no lateral curvature of the spine, which there is not. So now I will inspect my patient's gait. I'll instruct them to take 4 steps forward and then 4 steps back to me. Just noting that their fluid is movement and consistent, and it is rhythmic, and that there's no issues with their gait. So once I've inspected their gait, I can have the patient, you can go ahead and sit back down. Okay, so now I'm going to assess the patient's ligaments bilaterally for strength and a range of motion. So the first thing I'm going to do is start with the neck. I'll have my patient lean forward, lean back, circumduct. Okay, note that the patient has full range of motion in their neck. I'll also have them raise their shoulders. Don't let me push down. Okay? So I know, before that I would instruct my patient to not let me push their head to the left. Okay? Now don't let me push the head to the right. Okay? So I know that the neck has proper range of motion and appropriate strength. And then I will move on to assessing the patient's shoulders, which I just did with that strength test. And that would also be testing spinal nerve, or cranial nerve number 11, which is the spinal accessory nerve. So to check the range of motion for the shoulders, I'll have my patient, okay, now depress. Now roll your shoulders for me, okay? Noting that the patient has full range of motion in their shoulders. So then I can move on to their arms. So I'll have my patient extend, flex, circumduct, okay? Now note that the patient has full range of motion in the arms. Now I will test the strength bilaterally by having the patient hold their arm out. Don't let me press down. Don't let me pull up. Okay, and note that the patient displays appropriate strength. Now I would again perform this on the other side. Now I'll have my patient stand up, please. Hold on to this chair. So I will be testing the range of motion for the hips. So if you could abduct, adduct, abduct, circumduct. Okay, now please have a seat again. Actually, I'll test the strength. Sorry. So the range of motion I note is appropriate for my patient. So now I'll move on to testing the patient's strength. So I'll have them extend their leg out. Now don't let me push down. Don't let me pull up. Okay? Now note that the strength in the hips are appropriate. Now you can have a seat. So now I'll go on to assessing the legs and then the ankles. So for the legs, I will assess the patient. I'll have them extend, flex, and then circumduct. Okay? I would do this with both legs again. So to test the strength, I'll have the patient, so don't let me push down on your leg. Okay? Now don't let me pull up. Okay? So I note that the patient has appropriate strength in their legs, and I can move on to the ankles. So for the ankles, I have the patient extend, flex, circumduct. Okay? Noting that the patient has full range of motion. And then now extend your foot. Don't let me push down. Okay? Now flex it. Don't let me push up. Okay. So I note that the patient has appropriate strength and range of motion in all of the bilateral extremities, and that is appropriate. So now I can move on to assessing the patient's sensory ability. So what I'll do here is I would do a dull pain and light touch test, or sharp and dull pain test. So I would use something such as my pen light or a Q-tip. And so with the dull side, I would touch the patient's arm and have them tell me if they feel the pain, and then use the other side and tell me if they feel sharp pain. For soft touch, I would have the patient close their eyes and use a cotton ball and touch them somewhere on their body and have them tell me when I touched them and where I touched them at, to note that their sensory ability is intact. And then finally, I will finish out with checking my patient's reflexes. So I will start with this reflex, patellar reflex. I will find the bend in the patient's knee, and then with a reflex hammer, I will strike it and make sure that the patient's leg automatically extends, to note that deep tendon reflex is intact. Then I will move on to the dorsalis, or the pedialis. I'm checking for Babinski sign in this case. So what I'm doing is I will have the back of my reflex hammer, and I will run it up the patient's foot and note that the patient's big toe should curl down, noting that the patient has a negative Babinski sign. This is what you would expect for a patient of this age. So I believe that completes my complete head to toe assessment. So now I would finish with my post-procedural steps, and that will complete my assessment.